Depending on which facility you're in, you may take also samples for other respiratory viruses. So chest radiography, taking bloods and gases, these are not routine, but they should be considered in children who may have persistent fever, think empyema. They may have altered fluid balance. You may want to do the UECs, signs of liver dysfunction, LFTs, and those in respiratory failure may need a blood gas. It's important, depending on your situation or your context, to know what imaging may be useful for you. If you're in a context in which you can get a portable chest radiograph, that would be the best, so that you avoid patient movement to the radiology department. And if you have skills in doing point of care ultrasound, that is also an imaging modality that maybe need to be considered. Then we need to classify this patient in terms of their disease severity so that we can initiate appropriate treatment. And really, these guidelines follow our national pediatric guidelines, our protocol. So children in whom they have uncomplicated illness or mild disease, so those are the upper respiratory tract infection and the pneumonia, and they are suspected. Inpatient isolation is considered, and commencing of the antipyretics, if they have pneumonia, antibiotics, as you await the results of the testing. For these patients, because our health system will become overwhelmed, we need to consider having them actually being managed at home. But of course, maintaining the precautions that are as adequate. Children with severe pneumonia, those are the children who will present with danger signs, should be treated in the inpatient setting, and the treatment doesn't change. Still the oxygen, the antibiotics, so supportive care is crucial for these patients. And then identifying who is that critical case patient. These are the children in respiratory failure who may require mechanical ventilation. They may also have other issues. For example, they may be coming in shock or other organ failure, and this requires ICU care. And Dr. Kaiser, my colleague, she's going to take this up in the next talk. So this was really about principles and our approach when it comes to managing a child who is suspected to have COVID-19. Thank you.
Thank you, Dr. Marango. We'll now have Dr. Kaiser present to us on the critical care of a patient, a pediatric patient suspected to have COVID-19. And as she talks about COVID-19, I know right now many people are worried about ICU and the patients going to ICU. So I hope, Dr. Kaiser, you also mentioned, do we really need COVID for every child who is going to any ICU? Karibu, Dr. Kaiser.
Thank you very much, Dr. Kitui. I'm just going to build up on what Dr. Diana has set the stage for us. And just a recap in terms of the epidemiology from the data from China that showed over 90% of children presented with mild disease. So right now, we currently don't have data on children with severe disease presenting in extremis. And the current guidelines that we have are actually adults, based on adult data that are present in extremis with respiratory hypoxia. And my guidelines will be based on the adult guidelines, which have basically been adapted from management ARDS-net data. So, once you have these children who require admission, they will be under our radar and will be involved in the rapid response team and evaluation should they require further care. So once they've been instituted on low flow oxygen, then when intensivists get involved in their care, at this point we will have to determine the ones who require endotracheal intubation. This is generally just by risk stratification of their level of respiratory. Generally, severe work of these are patients who need to be intubated and advised. Exactly. It is experienced expert who can intubate. That would be an intensivist or an anesthesiologist. preferably done in a negative pressure room and minimizing the number of staff in that room to minimize exposure. So you want to get more senior nurses involved and role definition. Okay, and of course, infection prevention control measures, having your adequate PPE, which Dr. Diana has alluded to. The guidelines are talking about use of video laryngoscopy for intubation of these patients. The caveat is not many people have experience. So if you have experience, advisedly so, because then your proximity towards the patient airway is the distance is much much greater. You're not close to the patient's airway like when you're doing a direct laryngoscopy. However, it's not the end of the world. It's best done by somebody who is experienced at intubating. So away from those patients who require intubation, the patients who are on supplemental oxygen, continuous monitoring, targeting SATs, avoiding hypoxemia and hyperoxia, and of course you continue infection control precautions. And those who are noted to be worsening, please do not delay intubation. There are those patients who will have mild work of breathing, but they're hypoxemic on low flow oxygen cannulation. So these are patients, if you have the facility in your hospital where you may consider trial of high flow nasal cannula. Just a brief about high flow nasal cannula. It, just as it states, uses high flows. So you have pressures generated from your wall of about 3 to 4 atmosphere. Multiply that figure by 760 millimeters of mercury, generating flows of oxygen, which washes out your nasopharyngeal dead space. And it has been shown from data that it does give some level of PEEP, about 4 to 8 centimeters of water. So it can be used for improving oxygenation in these patients who have mild work of breathing and still hypoxemic on low flow oxygen. But should they meet the these are patients that you want to monitor 30 minutes down, 60 minutes at most. Their heart rate should be coming down by 10%. So you're monitoring their heart rate, you're monitoring their respiratory rate. If that figure does not come down by 10% within 60 minutes, this is a patient that you want to intubate. And their SATs should have improved, and their work of breathing should also have improved. Should you not have high flow nasal cannula, then you may want to try non-invasive positive pressure ventilation, where we have different interfaces, which can be a mask that covers both your nose and your mouth, or prongs. But as I said, the caveat is monitoring them very closely, looking at their parameters. And if there is worsening, please do not delay intubating this patient. So the guidelines of the respiratory failure and ARDS is, as I said, I am adapting them from adult guidelines because we do not have pediatric critical care guidelines based on the epidemiological patterns that has been shared. We haven't had children, data that has shown children that are being managed in the critical care unit. So we're still adopting the adult guidelines, which was based on ARDS net guidelines. An extensive study has been done in ARDS. And ARDS patients are generally divided into mild, moderate, and severe. You can either use the Berlin classification that uses your PF ratios, or the PR-ARDS classification that uses oxygenation index and oxygenation saturation index. So these patients who are intubated and mechanically ventilated, you want to institute lung protective strategy for ventilation using low tidal volumes, 4 to 8 mils per kg, which has been recommended by the ARDS net protocols, and limiting their plateau pressures to less than 30. This is really lung protective in a bid of preventing volume and barotrauma in these patients. It is reasonable to start them on empirical antibiotics because of bacterial infection. You'll have done your biomarkers that will be able to tell you whether there's a bacterial infection in addition to your cultures. And just avoiding hypoxia and hyperoxia, because we have data on the effects of hyperoxia in patients' morbidity and mortality. You have your supportive management, which includes, conservative fluid patients the patient in a critical care unit, making sure their calorie requirements are met, sedation, daily assessment of, other parameters, looking at their need for sedation, looking at their need for lines and tubes, what you'd normally do in a critical care patient. So now for the patients with a moderate to severe ARDS, these are patients who now you will find yourself using higher PEEPs and employing recruitment maneuvers, the traditional recruitment maneuvers, using PEEP tables. Prone ventilation has been shown to improve, their gaseous exchange, because we know that they have areas of heterogeneity, multiple areas of alveolar collapse, and inflammation and fluid in your alveolar. So PEEP helps to, keep your alveolar open and maintain keeping this alveolar open. So patients, when you are employing prone positioning, you want to keep them well sedated and may consider neuromuscular blocking agents, either intermittently or if you're having asynchrony while ventilated, then it is reasonable to start a 24-hour infusion and assess the need every day. These are patients who may go into multi-organ failure, have, you're supporting your cardiovascular system, especially when you're employing large driving pressures. This has an impact on your cardiopulmonary interaction. So you have a patient who is septic. On top of that, your cardiopulmonary interactions that affects their hemodynamics. So using corticosteroids may be of benefit in patients who have a catecholamine resistant, refractory shock. It's uncertain about the value of antivirals like clopinavir, ritonavir, chloroquine, and anti-leukin sixtosolution, as rescue therapy by some clinicians anecdotally, but the role is not yet defined. And currently there is a multi-center RCT that has been registered that is involving about countries as to the role of these agents. However, as I talked about, employing your recruitment maneuvers, PEEP, prone ventilation, keeping these patients well sedated, ensuring ventilator synchrony. The role of inhaled nitric oxide from ARDS data, it does improve your oxygenation index, but has no mortality benefit. But there are people, some clinicians anecdotally in the adult population who are using it. And of course, if your oxygenation index is not improving, then you want to stop it as soon as possible. Patients who have refractory hypoxemia on very high ventilator settings, with oxygenation index more than 40, you may consider VV ECMO. This doesn't really apply to our setup because we're not doing ECMO here yet, but it's one of those rescue therapies. As to whether it has an impact on their survival rate is from ARDS data, there's no impact on their mortality. So still a gray area. So as Dr. Umbeva had alluded, COVID-19 described as this strange disease, strange pneumonia, still a new phenomenon. We actually don't know. When you talk to clinicians, we are just extrapolating data, from ARDS management. So we, in a way, quote unquote, we don't know what we're doing, but we're trying our best based on other pathologies. You're going to have demands on space, beds, mechanical ventilators. So you have to have a backup plan like in our setup, because we've not even hit the steep slope of the curve, we've not even started. So this is the best time for us to start planning our ICU, ICU care and ICU facilities, because you will also have pressure on your supplies, monitors, ventilators, ECMO, that doesn't apply here, PPEs especially, that's the most important, okay? Staffing, we don't have that many intensivists in the country. We don't have that many pulmonologists. It's going to be a multidisciplinary team. Intensive care nurses who are trained, we don't have that many, and respiratory physiotherapists who are our proxy respiratory therapists, are not that many. So this is going to hit us hard, and this is really the time when we should actually start planning the event that we get overwhelmed. And this is basically
Dr. Kaiser,
yes.
Dr. Kaiser, sorry, we are a bit behind time. Can't you just wind
So
up
this is
the
my
next
last
one?
slide, basically showing a checklist of how you should be prepared for this pandemic. Thank you very much.
Sorry, we are getting a bit behind time and we had to rush you. Our next presenter is Dr. Christine Karanja, who is an infection disease specialist at Gertrude's. And Christine will tell us about the other pediatric services. Karibu, Dr. Christine.
Good afternoon, everyone. I hope that you can hear me well. And as we wait for the slide deck to be loaded up on the screen, I first want to mention that what I'm going to share is a collaborative effort among many pediatricians. So this, we were tasked to make guidelines by the Ministry of Health, the Division of Neonatology and Child Health, and through the members from Kenya Pediatric Research Consortium and Kenya Pediatric Association. We had an online platform and a few of us sitting in, and we came up with some recommendations, some of them just thinking and deliberating because there was no evidence, and others we used the available evidence. I'm still waiting for the slides. I don't know, are they ready or shall I just go on? So we were tasked with coming up with the strategic guidelines for 5 areas: isolation facilities for children, triaging children in OPDs, care in newborn units and kangaroo mother care facilities, routine POPCs, and routine immunization services. Still can't see the slide deck. Is it coming? Okay, I'll just go on. So regarding isolation facilities for children in health institutions, we already have the available evidence that isolation, hand washing, wearing of masks, gowns, and gloves may reduce transmission. But on the other hand, in children, there is the risk of post-traumatic stress disorders. And so we have to putting all these issues into consideration. And now in looking at all those issues, these are the recommendations that we are making. We say that all counties should identify isolation facilities that are fit for children, and if possible, include a play area. If possible, get just a building with a compound, and that can serve as a play area. Then it is desirable that this facility should have inbuilt oxygen ports, and if that is not possible, there should be designated portable oxygen for use in that facility. And the overrider is that the facility should have all the infection prevention and control requirements as set out in the national guidelines. So how do we classify the children to be isolated either at home or in the hospital? So we need to first qualify the status of the child, either well or unwell, and also the status of the caregiver, because caregivers are close contact and they can also be unwell. So if we have that the child is suspected or confirmed COVID, but they are both well, we can do home isolation. So home isolation, I will not go into the details of how we should do home isolation, that is covered in another document. But where the child is unwell, meaning that they meet criteria for inpatient care, but the caregiver is well, both the child and the caregiver can be kept in the designated facility for inpatient isolation. Where the child is well, but the caregiver designated becomes unwell, meaning that they need inpatient care, then you'll have to look for one other alternative caregiver who will be designated to stay with the child throughout the period of hospital isolation. Moving on to the next point, that is triaging of children in OPDs. That has already been covered by, I believe I am now in slide 8, so we can just scroll up to slide 8. And regarding, okay, next slide, triaging of children in the OPDs, we have available evidence that from the clinical guidelines from WHO and the consensus report by the pulmonology group. And this recommend that all children should be triaged. Every child with acute respiratory illness, cough and fever should be triaged. And I will not really dwell on that because that was covered very well by Diana. And so we'll go to the newborn units and the kangaroo mother care facilities. Please, can you take the slides up to there? I can see we are really struggling with that. I think there's no picture to show, so I will just stop. So the available evidence, we are now in, I believe, slide 14. With the available evidence please, about kangaroo mother care and newborn units. Skip that, that has already been covered. Go up to slide 14, please. Yes, the next slide there. Okay. Regarding the available evidence that we used so that we can come up with recommendations for NBUs and KMC facilities, no vertical transmission has been documented. And amniotic fluid, cord blood, throat swabs from neonates were tested negative. Breast milk samples from the mothers after the first lactation were also negative. So caregivers and healthcare workers, this is what we recommend, should remain cautious not to infect each other and the babies. Next slide, still to do with that. And you go to the next slide. So our provisional recommendations, one, go back to the previous slide, please. Go back to the previous slide. So infants born to mothers suspected, probable, or confirmed COVID-19 should breastfeed while applying the necessary infection control prevention. Symptomatic mothers who are breastfeeding or practicing KMC should continue, but practice the respiratory and environmental hygiene as set out in the IPC guidelines. Breastfeeding counseling and psychosocial support should be provided to all pregnant women and mothers of infants and young children, regardless of the COVID-19 status. Wherever possible, mothers should both continue to express and also breastfeed, regardless of their COVID-19 status, with appropriate IPC. If the mother becomes too unwell to breastfeed or express milk, then this is where we can use breast milk substitutes as per the other guidelines for severe illness in mom. So kangaroo mother care and rooming in continue, regardless of the COVID-19 status. Health workers with respiratory tract illness, it doesn't matter whether it's just a common cold or any other non-COVID, whether it is COVID or non-COVID, they should be exempted from NBU duties until recovery. Only one caregiver should be designated for the entire duration of admission in the NBU. So we do not want interchanging of caregivers in the NBU. No visitors should be allowed in the NBUs, and trainee numbers should be drastically reduced in the NBUs. All this in a bid to minimize the COVID transmission. Now, to the pediatric OPCs, outpatient departments, this is where we are seeing the patients with the chronic illnesses. What should we recommend? Let's go to the next slide. I believe we are now in slide 18. So available evidence regarding POPCs, we should minimize exposure by staying away from hospitals from non-urgent matters to reduce transmission. This not only protects the child, but also reduces overstretching of the health systems should the cases of COVID-19 surge. Next slide. So based on the available evidence, what are we recommending for our POPCs? One, routine POPCs should be suspended. Let us explore the mechanisms that can allow us to supply medication for our chronic patients. We should allow caregivers to collect medicines without the company of the child. Now, what if the child is unwell and needs to be seen? What should we do? One caregiver, not a whole family. One caregiver can bring the child to pediatric emergency, and from there, they will be seen. But for the health workers, please, minimal contact time, but try as much as possible to be thorough, but minimize contact time. The infection control considerations should be adhered to as per the guidelines. So adequate PPE for the healthcare workers, hand hygiene, disinfection of frequently touched surfaces and equipment, including stethoscopes, should continue. Next slide, please. About our immunization programs, what are we saying? Let us first look at the evidence available. We have, from the Ebola outbreak in Sierra Leone in 2014, the routine immunization services literally collapsed. And we saw that there was a rise in vaccine preventable illnesses because children did not get vaccinated, and there was no adequate catch-up program after that. So let us note that a fully vaccinated child is more likely to be protected from vaccine preventable diseases and the possible complications of COVID-19. Next slide, please. Yes. So our recommendations with the available evidence, please go back to, yes, that slide, stay there. One, routine immunization services should continue countrywide. But let us try to use the less crowded level 2 and 3 facilities to reduce exposure of children and caregivers. So where vaccination has to be done in the because vaccination has also to continue in the high volume health facilities. To minimize risk, we should set up separate spaces akin to an outpost service. And that is where we should carry out our vaccination services. If possible, mothers should be given scheduled appointments for routine immunizations. Infants and caregivers coming for immunization services should be triaged for possible COVID and directed to a point of care should they meet that. Next slide, please. Go to the next slide, please. We are also recommending, go back, please, one slide back. Community health workers should be deployed to mobilize mothers to continue seeking immunization services. Why do I say that? Because many mothers are wondering whether they should go on immunizing their children during this period. But the risks of not immunizing in our setup outweigh the risk of COVID. So let us advise them to continue seeking the services. And let us also prepare for possible catch-up of immunization activities at the end of the COVID-19 outbreak. We should continue communicating these emergency immunization strategies at all levels to minimize confusion and people doing their own things. I would like to stop there because the rest of the areas that I wanted to talk about have been captured. So thank you very much.
Thank you, Dr. Karanja, for your presentation on the other services in pediatrics. Our last presenter is Dr. Amkoe, who we all know is a pediatric pulmonologist working with KEMRI. And Dr. Amkoe will take us through the surveillance, where we are in Kenya, if we have any reported pediatric cases, and also what are the research opportunities. Karibu, Dr. Amkoe. Okay, and Dr. Amkoe, please keep time. We are already behind our schedule. Try to keep within the 10 minutes.
And your behavior is more important than anything. I told guys, if me nimeamua peace of mind leave those people alone.
Lazima nirudi niende kwa clinic ni confirm hizo
If you don't ask me, I just look at you but even
Can you hear me, John? Can you hear me?
Well, we can hear you, yes.
Can you hear me?
Yes.
Okay, you have jumped the slides.
Okay.
Can you go back?
All right.
Can you go back? Can you go back, please? Okay, let me just read from here then. For surveillance, as I was saying, is that it can provide data can provide information that can be used for assessing. Have I been muted again?
No.
Am I on?
Yes, you are on, Dr. Amkoe. You are on.
Okay.
comments.
Let me just start again that surveillance is important in terms of monitoring trends and rapidly detecting cases in counties where there are no cases and look at the trends where they've reported cases. It can also provide information so that it can know the risk assessment as well as know how the response measures are working. But to do this surveillance, you're required to collect data, and that data needs to be collated together and stored and need to be analyzed and then information to be used. So the most critical part is a tool. We have the government tool for case definition investigations. And that particular tool, I could see is not really child friendly. So I think some pediatricians should join the team so that they could add some things to that particular area. But some important things in the tool that is required is case definition, which you can see from Diana, that it is a fluid area. And as many cases come, we might actually open it up. And then we have to also define what the transmission patterns are, which means we have to get information of the movement or where the people are. And then we have to define who the contact is. Is where the child has been for a few hours? Is where somebody has had a contact for a longer period? We have to define that. And then, of course, you are going to keep on updating this information and looking at it. So I went into the particular tool and tried to check what areas we probably may be missing cases. We might miss information. So I looked at some areas already they have some information in terms of identifiers, but not all. For example, we will not be able to know about them whether a child is malnourished or not. So I think some of that information needs to be collected. Some of the comorbidities they're discussing, like even the one that I mentioned earlier, are not listed there, they're listed as others. For example, sickle cell disease that is common in our areas and other chronic conditions that are more common in children. And then if you look at symptoms, they actually monitor, they measure things like shortness of breath. I think we should use words like difficulty in breathing, otherwise we might lose some of this information. And then what we actually need to look at for all children is also things like the app. We need a proper app, which I think they're developing, that will collect all this information, either fed to the HMIS and other people. Now, who is supposed to collect this information? At the moment, the EOC is collecting the information, but I'm wondering from where? Is it from RRT? Is it from other places? Like I was looking at the information that's coming straight to EOC. Should we have certain programs? For example, TB has got a program called TIBU. They can collect this data and feed it to EOC. Then I looked at the admitted cases, and look at the admitted cases, you will not be able to segregate children into whether they had severe disease or non-severe disease. So those are areas that I thought should be included in some of the information that they have there. So I'll leave there, but someone asked whether we have cases of children. That one, I think we'll wait for the minister to say, but we definitely will be having children of different ages. People wonder why children are not being affected. I think it's some of the data that we need to see. Is it because there were fewer children being exposed, or is it because children are immune? We are not so sure about it. In fact, some of them will be some research question to find out when children get a lot of respiratory diseases, they're also exposed to corona, and that corona viruses also protect them against the SARS-CoV-2. We are not so sure. So looking at then from a quotation from each research thematic areas, and then to support research priorities in our global research platform prepared for next disease epidemics, that's allowing for accelerated research and R&D. Now, the research topic discussed included natural history of transmission and diagnostics, which you should look. Sorry? Animal, because you know this is a zoonotic disease, and whether we have been infected by animals, we'll also infect animals. Epidemiological studies, clinical characterization and management, and then therapeutics and vaccines, and then of course ethical consideration, because doing research in pandemic areas are a little bit more complicated. I'm ahead of you. I can see I'm ahead of you in that area. Can we go to such areas? Almost the last slide. If you look at the therapeutics, some of the therapeutics that we need to look at including in children, are some of those drugs that I've mentioned there, which are not go one by one, but suffice to say that none of them has completely been shown to be effective, even though chloroquine has shown better than all the others. But these are they're still under research consideration, so we should not use it unless using it under research consideration. This includes drugs like chloroquine, Aletra, interferon alpha, remdesivir, favipir, and Kevzara. These are anti-leukin-6 because, you know, some of the severe disease is thought to be due to cytokine storm, and interleukin-6 is a good marker, and also blocking it is being researched to find out whether it can assist. Now, what we're looking at in Kenya, these are research areas, is that Professor Anzala, what we were looking at mainly was epidemiological mathematical modeling, so that you can see which areas are going to be affected, which age groups are going to be affected, and what are the factors that could affect this. We looked at Cambridge and other people, and we divided this area into other 4 thematic areas. And we thought that areas that people should look at includes public health and epidemiology, and this will include, of course, just mapping of cases, and then accessibility of diagnostics. As you can see, many cases that centers are factors that lead to gender differences. And then laboratory sciences will include genetics. Sorry. Like genetics, because some of these viruses are changing with time, and we don't know whether changing time they'll become more pathogenic or less pathogenic. And then validation of some of the tests that we'll be using. But most important is to look at this immunity of children, how much of our children already have some immunity against the other coronaviruses, and how many actually probably may be having some clinical disease, and we have not caught them. And then clinical trials, and of course, clinical management. In clinical management, we also want to find out about some of these things. For example, like the ACE2 receptors, both for treatment sake and the expression, and seeing whether that expression makes us get more severe disease or less severe disease. Studies have been contradictory. Some say that ACE may be helping to protect the lungs, and people think that ACE being a receptor could help more viruses to enter because they enter through that receptor.
Hello, Dr. Mkoya. You seem to have gone off again. We can't hear you. Dr. Mkoya?
He must be on the phone. I think because of time, we'll just go to the Q&A.
All right, thank you, Dr. Mkoya. At this point, we are already behind time. So we will go on to the question and answer session. You will be selected to ask your question by one of our coordinators in the research area. So let's start our question and answer session. Karibuni.
Hello, my name is Dr. Rhoda Kalondo from Quality Healthcare Department. Thank you for joining us in today's sessions. We've been having these sessions for the last 2 weeks, so karibuni sana and asante. Now, since thank you also for letting us where you're listening to us from and where you work. Thank you so much for that. There's one question from David C. And David is saying, I have 2 concerns or questions. I have just read somewhere that a clinical officer has been diagnosed positive with COVID-19. I'm wondering whether this was from asymptomatic cases or this clinical officer was in the front line fighting the virus. The second question is, the FDA approved malaria drugs for treatment of COVID-19. Is the Kenyan government considering using the same for treatment? And how much supply of these drugs do we have in Kenya currently? Dr. Mbeva or Dr. Diana, any of you can take this up?
Perhaps the last question about the chloroquine, I'll ask Dr. Mukoya to comment. About the clinical officer, I think for us, we might not have that information at the moment.
Hello, please kindly mute your microphones. Dr. Dana is talking. Thank you.
It might be easier for you to mute all of us.
Hello, please mute your mic.
Regarding the question on chloroquine, I think Dr. Amukoya alluded to this, that we don't have very good evidence and lots of studies are being done, but there are some of these things that are probably plausible, and maybe he may want to comment a little bit more if there's any ongoing study in the country.
There are no ongoing studies, but there are planned studies together with GNDI and a few other players on this particular disease, especially the hydroxychloroquine more than the chloroquine itself. But the studies have been very few, and the number have been very few. Not the studies, the numbers have been very few. So it is not it cannot be open for everybody. It can be used under certain circumstances. So I think at the moment, it'll be up to us to decide how we're going to use it, but I would prefer we use it only under research conditions. Some people have even, there have been reports of people having developing toxicity because of taking too much of this chloroquine. So it should actually be used also from a doctor's prescription if you have to use it. But at the moment, let's get more data before we can open up the. Or probably because the numbers are so small, we just, if we increase the numbers, we'll see a different story, we don't know. I'm through.
Hello, may I ask a question? Hello, may I ask a question?
I think you can go ahead. I'm not the moderator, but the moderator should.
Okay, let me.
Yes.
Okay, great. Let me just, very quick observation. Regarding the first presentation on clinical presentation of children, that study that was quoted, there were actually only, I think 700 something children who are actually infected, proven infection. And when they analyzed the clinical presentation, less than half of them had either fever, less than half cough, less than half had a red throat. Which means then, if we use the fever and cough screening criteria, will be another and they did not present the data on who had both or whether they were independent. So if we use that as a criteria, we will be underestimating will be missing many children who actually have a problem. It will be not a good way of screening. What the children had were 90% of them had a family member who had been diagnosed with who had created an adult member. They were part of a family cluster. So it was contact with adults who met the risk criteria. And I think that should be reflected in our screening criteria, that not just a fever and cough as we have it now. The next is that we are recommending home care. I think home care in our population is a bad idea. It would actually form the nidus of infection. There are two outbreaks that are described, one in France and another one in a city just outside Seattle, where hundreds of people got infected. And both of them, there was a child. It was a child who was asymptomatic in contact with an adult. The adult was also asymptomatic, and they went and passed on the infection to others. So I think where you are diagnosed as infected, even if you are asymptomatic, in our situation and given our limited resources, we should have isolation. And I agree that isolation for children should be different from that of adults. And then my final observation is that the mothers who are in kangaroo care, so these are going to be moms in the hospital, we need to quickly identify an area of isolation, because in that space, it's very easy for the disease to spread out to even others who are not just through local exposure. And then finally, as we manage children, let's have a minimum number of investigations that we do so that we're actually able to answer the questions about, clinical presentation, other surrogate measures of whether you're positive or not. For example, in the Americas now, they're not necessarily doing COVID testing all the time, because they say if you have a chest X-ray that looks like this or white cell counts like this, then that's good enough for them, okay? That's all. Sorry for the disturbance from the phone. I'm sorry about that.
Okay, thank you for that input, Professor Nduati. There was a question for Dr. Kaiser from Chol. And Dr. Kaiser, the question was, at what day would patients be extubated? I don't know if this has a direct answer, but maybe you can give it a shot.
All right, so the extubation criteria for COVID-19 pneumonia will be the same as what you would do for any other intubated patient. So this is a patient that you have to make sure that they're adequately oxygenating in terms of the event setting. So you have FiO2s that are less than 40, your driving pressures at minimal. These are patients who the other pathology, if they were in septic shock, they are off vasopressors and inotropes, they are neurologically awake, intact, off any sedation, any neuromuscular blockage. So that's basically what we use in our criteria to determine whether this patient is extubation ready. It does not change. It's the same criteria.
Okay. Thank you so much for that. We are really sorry for those who are not able to hear during the presentation. We will upload the slides on the KNH website, and then you can be able to access them from there. So there are several comments from Professor Ruth Nduati, and I think she's mentioned them in the speech that she's given us. And the first one is triage has not been taken into account, has not taken into account the clinical presentation of children in whole. There's a point on home management, point of infection to the community. There's need to collect standard clinical data as part of research, chest X-ray, white blood count differentials. Mothers on kangaroo care must be in isolation. Yes, that is it. So from George is asking, do we already have some stocks of chloroquine for treatment of COVID-19 cases? Dr. Mbeba? do you mind taking this? Where is he?
Dr. Mbeva got an emergency, so he had to leave.
Oh, sorry, Dr. Mbeva had to leave you in an emergency? All right, thank you for that input. Dr. Diana. Hello.
So, hello, I'm here. I don't know about the exact counts that are available. I know there is hydroxychloroquine. I know that there is hydroxychloroquine in some of the facilities, but I think Dr. Mukoe touched on this, mentioning that this is not the drug that we are going for. Remember, the treatment is largely supportive. Kaiser has taken us through what are the important things to look at, and Dr. Mukoe has raised the point about the research that has been planned for to understand how this plays a role in the country. Thank you.
All right, thank you for that. From Professor Gracie Rimo, hello everyone. Regarding research on epidemiological modeling, we need quality patient data. Any effort KNH will make on this? Dr. Kinuthia, do you mind responding to that? Dr. Kinuthia is the head of research department KNH, and Professor Gracie Rimo is asking if, regarding research on epidemiological modeling, we need quality patient data. Any efforts that you're making in this?
Yes, we are working on standardized instruments which can.
We've lost Dr. Kinuthia.
Yes, I wanted to say that you can hear me. Yes, we are working on developing standardized instruments to collect data. So that is already being addressed. We've had several meetings, and we'll be able to get data that we can be able to analyze and understand and help us to better understand these.
Thank you, Dr. Kinuthia, for that feedback. As you hear, there's data that is being collected from the KNH side. We are standardizing the data. So very soon after this is over, we should be able to roll out some data. Can I add something? From Mercy Kamau, Mercy is asking any guidelines on venous thromboembolism prophylaxis in children with severe acute respiratory distress syndrome. Dr. Kaiser.
Okay, there is not much data on use of VTE prophylaxis in children. This applies to generally all children admitted to the pediatric critical care. However, we need to be cognizant of the fact that when we have invasives like central lines in indwelling hemodialysis catheters, these are invasives that are likely to get provoked thrombus. So be cognizant. So part of your ICU care bundle dailies, and you want to assess daily, does this patient need a central line? Is it time to take out the hemodialysis catheter? Because these are the agents that will provoke a thromboembolic phenomena, and usually we'll treat. But adolescent patients, yes, we may actually start use of chemical prophylaxis or use of thromboembolic stockings. But generally in the pediatric population, we do not have any guidelines generally. But just be cognizant of invasives that are likely to provoke and certain pathologies. Right. Yeah.
Thank you for that feedback. Professor Obimbo, I will unmute you. I've seen you've commented that you have a comment to make. So let me unmute you. Hello.
Yeah, hi. Lisa Obimbo here. First, thanks to all the speakers for such an excellent cover of the topic. I just have 2 comments. One is that in the Chinese series of 2,000 children, when I studied the age group information, I noticed that there's certain age groups that had higher percent of them having severe or critical disease. The child under 1 year, 11% of them, 10.6% of them had severe to critical disease. And then the age group 1 to 5 years, 7% had severe to critical disease. And then the older children above 5 years were similar to what they were seeing in the, you know, in the adults, excluding the geriatric age group. So the children above 5 years, about 3% were having severe to critical disease. So I think the point to note, even as we watch to see what pans out in our own pediatric population, is that the child under 5 years is generally more vulnerable and has a slightly increased, two to threefold increased risk of severe disease compared to the teenager or the young adult. The second is in the series where they described in one children's hospital in China, Wuhan, where they described children who they admitted to the ICU. Those children, their age range was from 2 months to 15 years. And generally, they had the classic symptoms of severe dyspnea, fever, and cough in the majority of them. Their chest x-rays were generally abnormal. And their lab findings were basically a normal or increased white cell count, increased CRP, normal procalcitonin, increased LDH, abnormal liver function. So I think there's data emerging that suggests to us that yes, some children will get sick and the young ones will get severely ill. And possibly in our setup where we may have delay in actually doing the viral PCR testing, we could use some of these clinical parameters, your white cell count, your lymphopenia, your high CRP, normal procalcitonin, elevated LDH, abnormal liver function. We can use those to make a clinical diagnosis. Of course, the history of contact in our setup helps us, just the way we do with TB. I think that history of contact with an adult or a member of the household, or being in a hospital setting where they may have come in contact, will help us to have high index of suspicion for a child who has COVID-19 disease. Because my sense is that we are not really having a wide testing of children, and we do have many children coming in with, you know, those classic respiratory symptoms. So those are my two observations. Thank you.
Can I comment?
Go ahead, Kaiser.
Yeah, thank you, Prof. Bimbo, about those observations. Actually, that's an interesting observation that I also observed in the data. And when we look at the pathophysiology in the adult data, they talked about, you know, the ACE2 receptors, whereas in the children, it's underdeveloped, immature. So I think just, you know, pointing out what you talked about, the high index of suspicion, history of contact, that history of contact will be very important and should be part of our triaging. And, you know, if they may have gone into places that they're exposed, but as a country, I think we cannot underestimate the fact that everyone is actually vulnerable to COVID, including, you know, your infants. Yeah, thank you for that.
All right.
Other comment,
thank you for that. We have two more questions from George. George from Kisumu, thank you so much for staying locked in. How readily available are clinicians to manage the said escalating cases of COVID-19 cases in pediatrics? And the second one is, can children below 5 years get infected, being that their immune system is dynamic in the development process? Dr. Kaiser.
Okay, I'll answer about the children. It's still a gray area, but if you look at that study that was published on the pediatric COVID-19 cases, it's a bit puzzling because of the hypothesized pathophysiology of COVID-19 using ACE2 receptors in the adult population. I think for us in our setup, we just have to have very high index of suspicion. And just as Prof. Obimbo has alluded to, and Prof. Nduati, in terms of the screening and triage and the history taking, that has to be really directed. You cannot just make assumptions. And once you're able to stratify these patients from your history taking and triage, then it shouldn't be a problem identifying these patients. So my answer to less than 5-year-olds predisposed, I think they are predisposed. As we go along, we haven't yet hit the steep curve, and we've not yet peaked, but perhaps our data from Africa might be different, and we might start seeing children. So just high index of suspicion and look for it.
The comment I want to make is about testing. If we don't test, we will not know. And so testing really needs to be advocated for. And I hope that we all know the numbers to call in the different areas that we are in. If in doubt, please call the 719 number and you'll be directed to the RRT teams that can come over and test. And also, like for us in Kenyatta, we have testing being done from the teams in Bagathi. And I think for us to know what is happening for children, if we don't test, we won't know. So and if we're not asking for the test, then they'll think it's not important in children. So I think this is my urge to everybody. And remembering also the mechanisms in the whole country that have been put in place in terms of testing. Some places might not have the benefit of having the chest radiographs to see these bilateral opacities or the lymphocytes and the LDH and the ferritin. But I think the mechanism for testing is out there and we should actually use it since it's been deployed. Thank you.
I have just one additional comment, if I may be allowed to comment.
Excuse me. We are 30 minutes past time. Maybe I can ask 2 more questions from the people in the chat box, and then we can let one person make a comment, and that will be the end of today's session. All right, thank you. So sorry, Dr. Osano, I can see you would address your question to Dr. Mbeva. Unfortunately, Dr. Mbeva is away, he's had to attend to an emergency. There's a question for Dr. Kitui. Dr. Kitui Miriam is asking, has KNH procured pressurized air purifying respirators for those in PICU who do intubate patients and for respiratory physiotherapists? The recommendation by Dr. Kaiser's presentation was to have negative pressure environment. Do we have that in KNH? Dr. Kitui?
I think the PPE that is available in KNH is being shared, especially at our infectious disease unit in Bagade. We have a few available. We have not had a confirmed patient admitted in the PICU that we would need to give them the PPE, but definitely if we do have a patient, we will make the PPEs available for them so that we are not exposing them to infection. Maybe Dr. Kinudia can also add on, being the research.
There's negative pressure rooms in the KNH infectious disease unit, and they have, this is mainly for the adults, and they have isolation cubicles, and they do have a vent there. In Bagathi, they don't have negative pressure, but they do have an isolation center there with 4 ventilators. And a lot of work is ongoing to improve the setup in KNH.
Okay, thank you, Dana, for that input. Let me ask one question to Dr. Christine Chege from Gloria Omosa. Dr. Christine Gloria is asking, kindly comment on the said protective role of BCG vaccine, if any. Could we add this to the proposed areas of research? Hello, Dr. Christine. Hello.
Yes, hello.
Yes, there's a question from Gloria Omosa. And Gloria is asking, kindly comment on the said protective role of BCG vaccine, if any. Could we add this to the proposed areas of research?
Okay. Regarding the use of BCG vaccine in the COVID-19 situation, studies are ongoing. Can we wait for firm recommendations before we make that across the board recommendation? Thank you.
Okay, thank you for that. Let Professor Obimbo make her comment before we end the session. For those who have not been able to address your questions, we are really sorry, but time is not on our side today, and we really hope to be able to address them again next week. So Professor Obimbo, let me unmute you so that you can be able to.
Okay, thank you so much for giving me a minute. I've actually tried to type my comment into the message. One is that we have a much higher proportion of our population under 15 years. In Kenya, 41% of our population is under 15 years, whereas in China, only 19% of their population under 5 years, and we have they have much fewer children per household than we have. So again, we don't know whether we can extrapolate their observation of very low percent of the total COVID cases being children, whether that's what we're going to see, because we have very different dynamics. Number two, we have much higher level of malnutrition among our children, and this also plays into their vulnerability to more severe disease, and yet they may present atypically. So I think we should watch closely, make sure we do our nutrition assessment, and for those who have moderate to severe wasting or they're underweight, really assess closely for possible COVID. Number three is also the observation that children tend to, a proportion of them may present with diarrhea. So even among the children who are coming in with diarrhea, we may want to consider. And I still stress that it's yes, we are going to ask for our testing, but as we do that, I think a full blood count, if we see a normal white cell count, or it's and a lymphopenia in a child who has fever and cough, I think just from that full blood count, these are surrogate markers that may help us to have high index of suspicion and say this child, we want them tested for COVID. Thank you.
So much, Prof. Bimbo, for your comments. We truly appreciate that. Lydia Kanyoro, unfortunately, I'm not able to ask your question here, but on Thursday we'll have Dr. Nyale from Respiratory and Infectious Disease Units. Maybe you can ask your question on cloth mask there, but I can say Professor Ruth Nduati has tried to address it. So thank you all for listening in today. We truly appreciate that you're able to find time and join us. Tomorrow we will be back again with the mental health team. So you're invited between 2 to 3 p.m. Thank you so much. And thank you to the presenters. We really appreciate the work that you put into this and the effort and your presentations. Asanteni sana. Have a nice evening.
Thank you.